evening. It's coming like this. Anyway, so this is an interesting abstract which was presented in last year ASCO GU. So it's basically the effect of CBM588 in combination with Cabo plus Nivo for patients with metastatic RCC. So to begin with, what is CBM588? It's a live bacterial product. CBM588 contains Clostridium butyricum, which is a butyrate-producing anaerobic spore-forming bacteria. And in preclinical agents, the studies appears to be bifidogenic. That means that it helps in producing the good gut bacteria, possibly through expansion of interleukin-17A producing gamma delta T cells and CD4s in the colonic lamina propria. So there has been previous studies in patients with non-small cell lung cancer receiving CPIs, showing a profound impact of CBM588 on both PFS and OS, and the benefit of CBM588 appeared to be more pronounced in patients who had received antibiotic therapy, and which majority of the oncology patients do receive. And a striking finding given that antibiotics have consistently been shown to diminish the impact of CPI, that is checkpoint inhibitor. So CBM588, it is an orally available live bacterial product containing a specific strain of Clostridium butyricum, and the proliferation in the lower gut is followed by production and release of butyrate. Compositional changes in the gut flora ensue with increase in the Bifidobacterium lactobacillus and other favorable species, and it has complex effects on the immune milieu that is seen. So previous studies where Nivo-IP combination with or without bacterial supplementation in metastatic RCC. So in these patients were randomized in 2:1 ratio. It was a 30-patient study, and stool metagenomic sequencing was performed. The primary endpoint was to compare the relative abundance of Bifidobacterium species at baseline and 12 weeks, and that was not met. And also there was no significant difference in Bifidobacterium species associated with the addition of CBM588 to Nivo-IP combination. Secondary endpoint was response rate, PFS, and toxicity. So you can see the results, they were very interesting. So just adding this CBM566, the PFS was significantly longer, CBM588, sorry, it was 12.7 months versus 2.5 months. So although not statistically significant, the response rate was also better, numerically much better, 58% versus 20%. And in terms of toxicity, there was no difference that was observed, and this data suggests that CBM588 appears to enhance the clinical outcome in patients with metastatic RCC treated with Nivo-IP combination. So coming to the study of discussion, that is the effect of CBM588 in combination with Nivo Cabozantinib in patients with metastatic RCC. So this study was sought to determine if CBM588 would augment the clinical outcome with TKI also in combination with IO. So the method was that patients who were 18 years or older with a good performance status and histologically verified metastatic RCC with no prior metastatic disease, no prior systemic therapy, patients were randomized in 1:2 ratio to either receive the standard Cabo-Nivo alone or versus addition of CBM588 dosed at 80 milligram twice a day. The primary endpoint was relative abundance of Bifidobacterium species in stool specimen at baseline and 12 weeks. And the secondary endpoint includes response rate, OS, and PFS. So this is a pictorial representation of the points that I discussed. 2:1 randomization, Nivo Cabozantinib plus CBM588 versus the standard Nivo plus Cabozantinib. So the results, again, they were very interesting. Around 30 odd patients, they were recruited with a median age of 65, and 17% had sarcomatoid features, 7% had predominantly papillary histology, 40% were good risk, 40% were intermediate risk, and 20% were poor risk. Metagenomic sequencing of paired stool specimens showed a significant decrease in diversity from baseline to week 12. In patients receiving Cabo and Nivo combination, there was no significant difference that was observed in those treated with Cabo-Nivo plus CBM588. And there was also no significant change in Bifidobacterium species. So these are the slides that were presented. You can see in the first top half that there is no statistically difference in terms of abundance of bifidobacterium species between baseline and week 12. And in the second part, in terms of bacterial diversity, in both the arms, there was no statistically significant difference that was observed in the bacterial diversity baseline and week 12. But the important part is the results in terms of the PFS and the response rate. So response rate were much better, around 63% in patients receiving CBM588 in combination with Cabo-Nivo versus 33%. That is almost more than double. You can see the median PFS also, and how there is a huge gap between the two graphs. The median PFS was not reached in patients receiving CBM588 versus 5.8 months in patients receiving Nivo-Cabo. And grade 3-4 toxicities, they were similar in both the groups. They were mostly no additional toxicity that was added with addition of CBM588. So conclusions are in this second prospective trial, which assessed the addition of CBM588 to immune checkpoint inhibitors in RCC, showed a consistent result with improved PFS and response rate. So obviously further translation efforts should be done, and many studies are underway to characterize the mechanism through which CBM588 augments the clinical activity. So with this simple intervention, this study showed a remarkable difference in terms of PFS and response rate. So this is what the author concluded in his in his last slide. So it showed that you can see the 3 questions that were answered. So did CBM588 change the gut bacteria as predicted? Answer is no. Did patients taking CBM588 have delayed tumor growth? Definitely yes. And did patients taking CBM588 have greater tumor shrinkage? Yes. So in this small trial, they were able to demonstrate a benefit in PFS and response rates. So obviously, this trial is very small and therefore should not influence the clinical practice. And we need larger clinical studies evaluating CBM588. So with this, I would like to conclude. Thank you.
Thank you. With permission of chairperson, I would like to make a comment here. So this is a very important study which highlighted the importance of microbiome in any immunotherapy. So we in India, first time we are starting a project of microbiome in lung cancer that has got funding from International Association for Lung Cancer, that has got a fund of $50,000. And we are starting that as a part of thesis of our DM resident. And the next step is to utilize CBM588 as a part of second prospective research, phase 2 going to phase 3 trial. And CBM588 has been under development in India also, so that we can start such a randomized trial, because we know immunotherapy will be much more accessible in next few years.
Cost, if someone wants to.
CBM588, it's not so costly. It monthly cost will be not more than 5,000 per month. So it's much cheap intervention, and hopefully, as it seems, I can also say this is a preliminary result, but we know that microbiome has a lot of implications on the immunotherapy work, and hopefully we'll get able to get some good results which can improve the responses to immunotherapy.
There is a data.
Yeah. Same CBM5. So Clostridium botulinum 588 is. Yes. Thank you.